Welcome back to Breastfeeding Nurtured, all you need to know. In our last session, we discussed the causes of breastfeeding refusal and excessive crying, along with effective strategies for managing these challenges. Today, in session 7, Breastfeeding, Troubleshooting Not Enough Milk, we will learn to assess whether the baby is getting enough milk, understand potential reasons for inadequate intake, and provide practical strategies to help increase milk production. Let's start with our first slide. This session focuses on understanding breastfeeding refusal and its management. By the end of this session, you will gain the ability to identify common reasons why a baby may refuse to breastfeed, examine individual factors that contribute to breastfeeding refusal in specific situations, develop effective strategies to address and overcome challenges related to breastfeeding refusal, explain typical causes of low breast milk intake during the first 2 weeks of life and beyond, differentiate between actual milk insufficiency and perceived insufficiency. The causes and management of excessive crying were thoroughly discussed in the previous session and will be briefly referenced in this session. When considering the reasons why mothers introduce top feed or formula, one of the most common reasons that comes to our mind is the belief of not having enough milk. Many mothers worry that their milk supply is insufficient, but in most cases, babies are getting all the milk they need. If a baby isn't getting enough milk, it's typically due to problems with latch or suckling technique rather than an ability of the mother to produce milk. In the previous sessions, we have discussed the process of breast milk production, and it was highlighted that insufficient milk production in mothers is uncommon. If a mother believes her milk supply is insufficient, it is important to understand why she thinks that and assess if the baby is actually getting enough milk. Despite numerous common signs of insufficient milk intake which a mother quotes, only two signs are reliable indicators of insufficient milk intake. On weighing over a period, if the weight gain is lower than standard growth curves, it may suggest that the baby is not getting enough milk for proper growth and development. Secondly, when a baby produces fewer than 6 wet diapers a day with urine appearing concentrated darker yellow in color, it can indicate insufficient milk intake. It's important to note that a neonate who loses more than 10% of their birth weight or does not regain it within 2 weeks is considered to be showing a reliable sign of potential concern. Sometimes mother may feel they have insufficient milk based on their observations. In the next slide, we will explore the possible signs that will lead to this concern. Before determining whether the baby is receiving enough breast milk, let's first explore the mother's concern that may lead her to believe she is not producing enough milk. These signs include the baby seems unsatisfied after breastfeeding sessions, frequent crying is observed in the baby breastfeeds very often or for extended periods of time, the baby refuses to latch or breastfeed. The baby passes hard, dry or green colored stools. Stools are infrequent and small in quantity. The mother is unable to express milk when attempting to do so. The mother's breast did not noticeably enlarge during pregnancy. The milk supply did not appear to increase after delivery. Now, the above indications are the possible signs that a baby may not be receiving enough milk. However, it is essential to verify using reliable signs to be certain. They are weight gain and urine output. To assess if a baby is getting enough breast milk, this slide provides a concise summary of the key points we have discussed. It highlights both reliable and possible indicators, making it easier to differentiate between signs that definitely confirm milk intake issues and those that might raise concerns. This recap serves as a helpful guide for recognizing potential challenges and understanding when further evaluation is necessary. Let's get back to interpretation of reliable indicators. Most reliable way to determine if a baby is receiving enough breast milk is by monitoring and interpreting their weight gain. For the first 6 months, refer to growth charts designed for infants aged 0 to 6 months. It's important to note that gaining 1 kg per month is not always typical or necessary. If the baby weight gain does not follow a parallel pattern to the growth chart curves or shows a downward trend, it suggests insufficient weight gain. Review weight history by checking the baby's growth chart, if available, or any records of previous weights. If no such record exists, weigh the baby and schedule a follow-up weigh in 1 week later to assess progress. Interpret weight gain to know whether the baby is steadily gaining weight. A consistent pattern of growth suggests that the baby is receiving adequate milk. In the absence of weight records, it may not be possible to provide an immediate answer regarding the adequacy of milk intake. Regular follow-up and weight recording will be necessary to establish a clear picture of the baby's growth and feeding adequacy over time. Let's examine an example of weight gain for a baby exclusively breastfed using a growth chart. In this graph, the baby's birth weight is plotted at 3.5 kg. The weight has been recorded regularly every 2 weeks over a period of 12 weeks. By the end of 12 weeks, the growth curve shows a consistent upward pattern indicating that the baby is thriving well on exclusive breastfeeding. This consistent growth clearly demonstrates that the mother is producing enough breast milk to support the baby's optimal development. Let's continue analyzing the growth chart of the baby who showed consistent weight gain up to 12 weeks. From the earlier observation, we noted that the baby was thriving on exclusive breastfeeding with a steady upward growth curve. Now let's interpret the weight recorded monthly from 3 to 6 months. Initially, the growth curve becomes almost flat and then dips between 4 and 6 months. By the end of 6 months, the baby's weight remains nearly the same as at 4 months. Starting from the median line at 3 months, the growth curve eventually falls below the -1 z-score line. In simple terms, this means the baby did not gain weight as expected during this period, indicating potential concerns that need to be addressed. The second reliable indicator is the baby's urine output. Checking how often a baby passes urine can provide a quick assessment of whether they are receiving enough breast milk. Inquire from the mother about the number of times her baby passes urine daily. Adequate breastfeeding is typically indicated by 6 to 8 wet diapers per day after the first week of life, with babies generally passing urine at least 6 times a day by the 6th day of age. A baby passing a large volume of clear dilute urine is a strong sign of sufficient milk intake. If a baby is urinating fewer than 6 times a day, it may indicate insufficient breast milk intake. Additionally, for the babies older than 4 weeks, concentrated urine that is characterized by a dark yellow color or a strong smell can also suggest inadequate milk supply. This highlights that the frequency of urination offers a quick and valuable insight into whether the baby is receiving sufficient milk or not. Before moving forward, I would like to highlight some key points about urine output in newborns, as it is an important and reliable indicator of adequate breast milk intake. It's important to note that during the first week after birth, newborns may pass urine fewer than 6 times a day. A simple guideline to follow is On day 1, once in the first 24 hours. On day 2, twice a day. On day 3, 3 times in a day. On day 4, 4 times a day. And on day 5, 5 times in a day. Moreover, in the first 4 weeks, a newborn's ability to concentrate urine is still developing. Even when dehydrated, their urine remains less concentrated, making it less reliable as an indicator of hydration status. It is also important to note that disposable diapers can absorb urine, making it challenging to assess if a baby is urinating adequately. For mothers concerned about their milk supply, using cloth nappies can provide a clearer way to track the baby's urine output, provided this option is feasible for her. If the reliable indicators suggest that the baby is not receiving enough breast milk, it is crucial to identify the underlying cause before assisting the mother. Understanding the reasons behind this is vital, as early detection and timely interventions can greatly improve the baby's well-being and the mother's breastfeeding journey. We will now look into the common factors influencing milk supply and how they affect the baby's feeding. The factors which influence breast milk supply can be broadly categorized into four groups. Breastfeeding practices are issues related to improper techniques, infrequent feeds, or poor latch. Mothers' mindsets are issues related to stress, anxiety, or lack of confidence, which can directly impact milk production. Mothers' health affecting low breast milk supply include medical conditions or nutritional deficiencies affecting lactation. Babies' health include issues such as poor suckling, illness, or prematurity, which influence feeding efficiency. The first two reasons, which breastfeeding factors and mother psychological factors, are common, which should be looked first. The factors in the later two categories, mother's physical condition and the baby's condition, are less frequently encountered. It is relatively uncommon for a mother to face physical challenges that significantly hinder breast milk production. These less typical causes should only be considered if none of the more common reasons are identified. Let's explore the various factors contributing to insufficient milk supply, addressing each one individually to identify root causes and implement effective solutions, ultimately resolving the issue and supporting successful breastfeeding. Delayed initiation of breastfeeding can lead to significant challenges. When breastfeeding is not started early after birth, it may result in reduced milk production and a lack of stimulation for the baby's natural suckling reflex. Initiation within 1 hour after birth is critical to establish the breastfeeding process, as delaying it or introducing other feeds can cause the baby to refuse to suckle. Issues such as scheduled feeding, infrequent feeding, hurried or short feeds, and misinterpreting hunger cues can lead to insufficient milk intake. Feeding fewer than 8 times a day in the first 4 weeks or fewer than 5 to 6 times a day as the baby grows older is a common cause of insufficient milk intake. Mothers might stop feeding too soon, believing the baby has finished after a brief pause, or switch breast prematurely. In such cases, mothers should not wait for the baby to cry. Instead, learn to recognize early hunger cues such as lip smacking, rooting, or sucking on hands. Mothers should gently wake the baby to feed every 3 to 4 hours if they seem passive or sleep too much, especially in the first few months. The aim should be to breastfeed at least 8 to 12 times daily in the first month and adjust as the baby grows. Mothers should ensure that the baby feeds from one breast until they release it on their own, as this allows them time to receive the fat-rich hind milk. If switching to the other breast allows sufficient time for the baby to finish feeding from the first, hurrying through feeds should be avoided and baby given ample time to pause and resume suckling. Another issue of night feeds, which are essential for maintaining a good milk supply, especially during the early months of breastfeeding. You already know that the milk production follows the demand supply principle, with prolactin, the hormone responsible for milk production, being most active at night. Skipping night feeds reduces this natural stimulation, potentially affecting both the mother's milk production and the baby's ability to get adequate nutrition. So it becomes imperative to continue night feeds regularly to support the baby's nutritional needs and maintain the mother's milk supply until the baby is developmentally ready to go longer without them. Improper attachment is a key factor contributing to inadequate weight gain, particularly during the initial weeks of life. Therefore, ensuring that the babies are properly latched onto the breast immediately after birth plays a crucial role in establishing a sufficient milk supply. A baby who feeds from a bottle or sucks on a pacifier may suckle less at the breast, leading to a decrease in breast milk supply. To prevent this, it is important to encourage exclusive breastfeeding and limit the use of bottles and pacifiers to help establish and maintain a strong milk supply. Introducing complementary feeds such as formula, solids, or drinks like plain water, tea before 6 months can reduce the baby's frequency of breastfeeding, leading to a decline in milk supply. While the baby may still gain weight, the mother may notice a reduction in her milk production. To maintain a healthy milk supply, it is recommended to exclusively breastfeed for the first 6 months. Having discussed the key breastfeeding factors, it is equally important to address the maternal psychological factors that can impact breast milk supply. Let's explore what can be done to ensure an adequate milk supply in light of these psychological challenges. Mothers low on confidence, especially those who are young or lack family and social support, may struggle with self-confidence in their ability to breastfeed. This insecurity can be heightened if the baby's behavior, such as crying or fussiness, leads them to believe that their milk is insufficient. In such cases, mothers might resort to formula supplementation, which can reduce breastfeeding frequency and ultimately decrease milk supply. In such cases, educate and support mothers by providing them with evidence-based information about breastfeeding and its adequacy for meeting their baby's nutritional needs. Encourage participation in breastfeeding support groups or consultation with lactation experts if needed. Involve family members to offer emotional and practical support, creating a nurturing environment for the mother. Stress, anxiety, and even pain due to physical discomfort can also hinder the oxytocin reflex, which is critical for milk ejection. Temporary disruptions in this reflex can make breastfeeding feel challenging, potentially discouraging the mother from continuing. For stress reduction, encourage relaxation techniques such as deep breathing, gentle massages, or warm showers to help mothers feel calm and supported. Comforting measures need to be taken by addressing physical pain or discomfort through proper breastfeeding positioning and treating any medical issues like engorgement or sore nipples. Supportive environment needs to be created by providing peaceful and private space for breastfeeding to minimize stressors and distractions. Dislike of breastfeeding, rejection of the baby, and fatigue may be experienced by some mothers, resulting in negative feelings about breastfeeding, exhaustion, or even difficulty bonding with the baby. These feelings can lead to infrequent or short breastfeeding sessions and reliance on pacifiers or other substitutes, ultimately impacting milk production. Emotional support should be offered to help mothers process their feelings about breastfeeding and bond with their baby. Empathy and understanding can make a significant difference. Encouraging close contact by promoting skin to skin contact helps to foster bonding and stimulate breastfeeding instincts in both mother and baby. Rest and assistance should be encouraged and prioritized. Help should be sought from the family members for household tasks or baby care to alleviate fatigue. By addressing these psychological factors with empathy and practical solutions, mother can regain confidence, reduce stress, and build a positive breastfeeding experience that supports both their well-being and their baby's growth. In addition to the commonly discussed breastfeeding and psychological factors, less frequent causes related to the mother's physical condition can also impact milk production. These include medical conditions, hormonal imbalances, and lifestyle choices. Such factors require thorough evaluation and proper management, which we will now explore. Contraceptive pills containing estrogens can suppress milk production and should be avoided while breastfeeding. Progesterone-only pills or Depo-Provera injections are considered safer alternatives, but they should not be used until the baby is at least 4 weeks old. Diuretics may also lead to decrease in breast milk production and should be used cautiously by nursing mothers. Reports suggest that antihistaminics might affect milk supply. However, scientific evidence is inconclusive. A new pregnancy can also lead to hormonal changes that may reduce milk supply. However, breastfeeding during pregnancy is generally safe for most mothers and babies, provided the mother is healthy, the pregnancy is without complications, and she maintains a nutritious diet to support her energy needs. However, it may require careful consideration in those with a history of preterm labor or miscarriage. Severe malnutrition can compromise both the quality and quantity of breast milk. When mothers lack essential nutrients, the micronutrient levels in their milk may be reduced. However, women with mild or moderate malnutrition typically continue producing sufficient milk, though their own nutrient stores may be depleted if frequent breastfeeding is maintained. By addressing both the mother's nutritional needs and adequate breastfeeding practices, it is possible to support her health and the baby's growth simultaneously. Alcohol consumption can interfere with the baby's milk intake and may also lower prolactin levels, thereby reducing milk production. Similarly, smoking introduces harmful chemicals like nicotine into the breast milk, which can adversely affect the baby's health. To protect the baby while supporting the mother in making healthier choices, encourage the mother minimize or stop alcohol consumption. Since alcohol passes into the breast milk and may affect the baby's development, advise breastfeeding before drinking or waiting at least 2 to 3 hours per standard drink before nursing to allow alcohol levels to decline. Support the mother in reducing or quitting smoking altogether. Recommend smoking outdoor and away from the baby to minimize exposure to secondhand smoke. Retained piece of placenta in the uterus after childbirth can release hormones that prevent milk production. Once the retained placenta is removed, milk production usually increases. Women with hormonal disorders like hypothyroidism and other endocrine disorders may also fail to produce breast milk. Hormonal imbalance needs appropriate correction in these conditions. Inadequate breast development during pregnancy is a rare anomaly leading to low milk supply. If breast enlargement occurred during pregnancy, this is unlikely to be the issue. Let's now discuss certain conditions in babies which can also impact their ability to breastfeed effectively, resulting in reduced milk intake and potential challenges for both the baby and the mother. Preterm or low birth weight babies often lack the strength and coordination to suckle effectively. This leads to inadequate milk removal and stimulation, which can reduce the mother's milk supply over time. Expressing milk and providing it through alternative feeding methods such as cup feeding can help meet the baby's nutritional needs until they can breastfeed effectively. Blocked nose during feeding can hinder a baby's ability to suckle. Clearing the nasal passage and offering frequent shorter feeds can alleviate this issue and ensure that a baby gets sufficient milk. Babies who are unwell or weak may lack the energy to suckle strongly, resulting in reduced milk intake. Over time, this can lead to a decline in the mother's milk supply. Treating the illness promptly and feeding expressed breast milk during recovery can help sustain milk supply and provide the baby with essential nutrition. Babies with congenital conditions like a heart defect may struggle to gain weight. This can be due to consuming less breast milk as well as other impacts of the condition. Similarly, infants with structural abnormalities such as cleft palate, neurological issues, or developmental delays often face challenges in suckling efficiently, particularly during the early weeks of life. These challenges can result in insufficient milk intake and slow weight gain. Specialized care, including feeding adaptations and close monitoring, is often necessary to address these issues. It is important to know that management of the baby's condition focuses on addressing the underlying issue while supporting breastfeeding. This includes treating illnesses, adapting feeding techniques, and using alternative feeding methods like cup feeding to ensure the babies receive adequate nutrition. Avoiding bottles and pacifiers is recommended to prevent nipple confusion and maintain the breastfeeding relationship with timely interventions and guidance. Many of these challenges can be overcome, allowing both mother and baby to benefit from the advantages of breastfeeding. Beliefs about what can cause insufficient breast milk supply, but not all of them are true. Some commonly held misconceptions can create unnecessary worry or discourage mothers from breastfeeding. Let's address these myths and clarify the facts to help mothers feel more confident and informed. Mother's age does not determine her ability to produce sufficient breast milk. Both young and older mothers can successfully breastfeed. Resuming sexual activity does not affect breast milk production or its quality. Menstruation may slightly alter the taste of breast milk, but it does not decrease supply or harm the baby. Social disapproval or negative opinion by relatives or other family members do not impact milk production unless they cause significant stress to the mother. When returning to work, breast milk supply can be maintained by ensuring the baby breastfeeds frequently when with the mother and by expressing milk regularly during work hours. Baby's age does not matter. Milk supply naturally adjusts to meet the baby's needs at every stage of development. Post-cesarean mothers can establish and maintain an adequate milk supply with the right support and early initiation of breastfeeding. Preterm delivery does not prevent mothers from producing sufficient milk as long as they maintain consistent expression and breastfeeding practices tailored to the baby's needs. Breastfeeding multiple children over time does not reduce a mother's capacity to produce milk for subsequent babies. A healthy and balanced diet is ideal, but even a simple diet can support adequate milk production as long as the mother is well nourished. To summarize, mothers should focus on proper breastfeeding techniques, frequent feeding, and staying relaxed to maintain a healthy milk supply. We have explored the reasons behind insufficient milk production and how to assess whether a baby is receiving enough breast milk. Now let's focus on a systematic approach to support a mother whose baby may not be getting adequate milk. Let's take an example of a mother who says that she does not have enough milk as her baby wants to feed very often. The baby is 8 weeks old with a birth weight of 3 kg and a current weight of 3.4 kg. Assessing the baby's milk intake reveals that he has only gained 400 gram in 8 weeks. Next, we need to explore the mother's concern by using a structured approach. Gather a detailed feeding history. Begin by understanding the situation through careful listening and learning. Discuss the frequency and duration of feeds, the mother's feelings, and her work plans. In this case, mother gives history that her baby wants to feed very often. She sometimes has sore nipples, so she does not let him feed for very long. She delivered in the local hospital. The delivery was normal and she went home after 6 hours before the baby had started breastfeeding. Next, you need to assess the breastfeeding process. Observe a breastfeeding session to note that the baby's attachment shows less areola above the mouth and more below, with the chin not touching the breast. The nipple appears sore after feeding, indicating poor attachment. Assess how the mother holds the baby and whether the baby's position supports effective suckling. Next, we need to identify underlying issues. The primary issue is poor attachment, leading to ineffective milk transfer and insufficient milk intake. This is also the cause of sore nipples, thereby discouraging longer feeding sessions. There are no signs of illness in the baby and the mother is healthy with no evidence breast condition. History also suggested that the early initiation of breastfeeding was delayed, which may have affected milk supply. Further, with the same case, we need to provide tailored solutions to assist this mother and baby by employing strategies that build confidence and offer practical support. First, praise and encourage the mother's effort to breastfeed despite challenges and the lack of guidance. Next, explain the issue to the mother that her baby is not getting enough milk because they are not taking a sufficient portion of the breast into their mouth. Highlight that this also causes the sore nipple. Offer practical help to the mother in improving the baby's attachment to the breast to facilitate more effective suckling. Suggest extended feeding times which will encourage the mother to allow the baby to feed longer during each session to stimulate and increase her milk supply. Next, you need to ensure follow-up care to review the mother and baby's progress regularly. Ideally, meet daily until the baby starts gaining weight and the mother feels more confident. Typically, it may take 3 to 7 days for noticeable weight gain in the baby. We have explored the ways to support mothers struggling with insufficient breast milk. Now let's focus on a step-by-step approach to help mothers who are worried about having an inadequate milk supply even when they are producing enough. This highlights the importance of addressing their perceptions and thought processes as the issue may not be an actual decrease in milk production. Let's take an example of a mother who expresses her concern that she is not producing enough milk as her baby seems hungry all the time. The baby is 6 weeks old with a birth weight of 3 kg and a current weight of 4.2 kg. Assessing the baby's milk intake reveals that a weight gain of 1.2 kg over the 6 weeks almost aligns with standard growth curves, indicating the baby is receiving an adequate amount of milk. Next, we need to explore the mother's concern by using a structured approach. Listen and learn to understand any psychological factors and the mother's feelings about breastfeeding. Take history to gather details about breastfeeding practices and assess any medications the mother might be taking. The history reveals that the baby feeds every 2 to 3 hours, including several times at night, with each session lasting 5 to 10 minutes. The mother offers water between feeds, thinking the baby is thirsty. The baby was delivered normally at a health facility and breastfeeding was initiated with assistance from the midwife. The mother of the breastfeeding woman says to her that her breasts are too small to produce enough milk for the baby. Next, we need to proceed to understand the root cause of the mother's concern by assessing breastfeeding to observe the baby's attachment, suckling, interaction with the mother, and how the breastfeeding session concludes. In this case, it is observed that while breastfeeding, the baby's mouth is wide open and shows good attachment with more areola visible above his mouth than below, and the baby being held close, facing the mother with his chin near the breast. The mother stops the feeding session after about 5 minutes, not allowing the baby to finish and come off the breast naturally. Next, examine the baby for any illness or abnormalities. Also, examine the mother to assess her overall health, nutrition, and breast condition. On identifying the cause, it primarily appears to be the mother's lack of confidence influenced by external comments about her breast size. While the baby is suckling effectively, early removal from the breast prevents him from receiving hind milk, which is richer and more satisfying. Next, we need to counsel and support the mother to clear her thoughts of insufficient breast milk. Once the cause is identified, we need to employ strategies that build confidence and provide support to the mother and the baby. Acknowledge her concerns to accept her feelings about her milk supply and breast size. Appreciate the mother for the excellent growth of the baby as it reflects that he is receiving sufficient milk. Offer positive reinforcement and provide reassurance. Highlight the baby's healthy weight gain as evidence that he is getting sufficient breast milk. Point out the rich, creamy hind milk that becomes visible as the feed concludes, indicating its high fat content. Explain small breasts are fully capable of producing enough milk. Clarify that the breast milk contains sufficient water to meet the baby's hydration needs, making additional water unnecessary. Suggest better practices. Advise her to let the baby feed until he naturally comes off the breast to ensure he receives more hind milk and is more satisfied. Suggest stopping the practice of offering water as this may reduce the baby's intake of breast milk and consequently her milk production. By addressing these concerns with empathy and factual information, the mother can gain confidence in her ability to meet her baby's needs through breastfeeding. Summarizing the two scenarios, that is, supporting a mother concerned about her milk supply whose baby is truly not getting enough milk or is actually well fed, involves a similar approach. Poor attachment at the breast is often the underlying cause of behaviors that lead mothers to believe their babies isn't satisfied even when milk supply is adequate and the baby is receiving enough. Addressing these concerns requires counseling skills and understanding of breastfeeding patterns and the ability to assist with positioning and attachment. With the right support, these challenges can typically be resolved. Before we conclude this session, I would like to address an important topic that often causes concern among mothers, the relationship between stool output and milk intake. Let's clarify these misconceptions and provide guidance on understanding normal stool patterns in breastfed infants. Some mothers wrongly associate milk supply with stool output. However, the fact is that stool frequency varies widely among infants and is not a reliable indicator of milk intake. What is the normal stool pattern then? During the first 2 to 3 or 4 days, dark green meconium is passed. However, persistent meconium beyond 4 to 5 days may indicate insufficient milk intake. Around 4 days, the stools transition to brown or yellow as milk comes in. Typically, the baby passes 2 to 3 substantial stools daily and sometimes a small stool after each feed. After 3 to 4 weeks, the stool frequency may reduce to once every 3 to 4 days or even a week, which is normal. However, stools are usually large and semi-liquid at this stage. Stool output in babies, though not entirely reliable, can offer some insights into milk intake. Small dry stools may suggest inadequate breast milk intake, while diarrheal stools are watery, unlike the typical semi-liquid consistency. It is important to note that in exclusively breastfed babies, passing 8 or more semi-liquid stools per day is normal and does not indicate diarrhea. We have discussed that a mother's milk is the best option for feeding her baby. However, in some situations, it may not be available or the quantity may be insufficient. Therefore, it may be necessary to assist a mother in identifying an appropriate additional source of milk for her baby. The term supplements refer to extra milk provided to a baby during the first few months of life. This is distinct from complementary feeding, which involves introducing solid foods alongside breast milk later in infancy. When deciding on supplementation, the guiding principle should be prioritized. Direct breastfeeding, which is the most natural and beneficial, should be the first option. Using mother's own express milk provided by cup or tube if necessary comes next. If the mother's milk is unavailable or insufficient, pasteurized donor human milk given via cup or tube is the next best alternative. Formula or animal milk should be the last resort, used only when no other options are feasible. Simultaneously, during supplementation, the mother should be encouraged to breastfeed as much as possible to maintain and increase her milk supply. Provide only the necessary amount of supplement to support the baby's healthy growth. Use a cup for feeding the supplement to avoid nipple confusion and support oral development. It is to be noted that replacement feeding, which involves feeding a baby who is not breastfeeding at all, will be discussed in detail in one of our upcoming sessions to ensure a comprehensive understanding of all the feeding options. We have concluded session 7, breastfeeding, troubleshooting, not enough milk. In the upcoming session 8, breastfeeding techniques for low birth weight and sick babies, we will explore why breast milk is vital for low birth weight and sick infants, how to support breastfeeding during illness or jaundice, and techniques like cup feeding to ensure these babies receive adequate nutrition. We encourage you to share your thoughts, questions, or any topics you would like us to address in future sessions. Feel free to reach out via email at rajinder_gulati@hotmail.com. Your feedback is invaluable as we strive to create informative, helpful content. Thank you for your engagement and we look forward to continuing this journey together. Have a good day.